Your audio. Hello?
Okay. I don't know where the microphone is.
Hello? Hello? Thank you for those that are here. We're just going to be starting in the next few minutes to see if anyone else comes in. We're just going to start in another 5 minutes to see if anybody else shows up. Thank you. All right, so I think we're going to get started now. Thank you for coming. For those who don't know me, my name is Sam. I'm one of the new pharmacy residents, and today we're going to be talking about acute ST segment elevation myocardial infarctions. So just before we get started, I have nothing to disclose, no financial interests or affiliations with anything that I'll be talking about today. So our pharmacist objectives will be to describe the risk factors for acute coronary syndrome, to define ST segment elevation MIs versus non-ST segment elevation MIs, to select relevant guideline-directed medication therapy, to identify proper dual antiplatelet therapy based on patient-specific factors, and lastly, we'll just briefly go over some factors for potential readmissions. So first, describing risk factors for acute coronary syndrome. So we just want to go over what exactly is acute coronary syndrome. So what it is there's a sudden reduced blood flow to the heart, and this reduced blood flow can cause any type of myocardial ischemia or infarction. And what ACS describes is it's basically an umbrella that encompasses 3 different types of coronary artery disease that are associated with sudden plaque rupture. And those include unstable angina, NSTEMIs, and STEMIs. So talking a little more about what each of the acute coronary syndromes are. So stable angina is when there's an increased demand due to plaque in the vessels. And because of this, the vessels have trouble dilating enough to meet the demand of the heart. At stable angina though, even though you do have chest pain at rest, it does go away. In comparison to unstable angina, where you have chest pain at rest, but you also have plaque rupture and thrombus formation, which can cause partial occlusions of the blood vessels. And for both of these, our EKGs are usually normal with normal troponin levels. So the more serious forms of acute coronary syndromes are your NSTEMIs and your STEMIs. So your NSTEMI is when there's plaque rupture and thrombus formation, which causes partial occlusion of the blood vessels. And this results in injury and infarction to the myocardium. And you'll see that this ischemic damage is manifested on the patient's EKGs. And I'll speak a little bit further about that in a few slides, but you also can have some type of elevated troponin levels. And then your most serious type is a STEMI. So STEMIs are complete occlusions of the blood vessel, which results in direct injury and infarct of the heart. And again, this is reflected in EKG changes and troponins, and these are directly due to the death of the cardiac myocytes. So some risk factors that are associated with acute coronary syndromes. We see the age can differ in men and women. Men are more prone to experiencing acute coronary syndromes at a younger age, but also we take into consideration patients' hypertensive status, if they have any type of lipid abnormalities, as well as diabetes. And mainly we see that lifestyle modifications can have a direct impact on acute coronary syndromes, especially patients who smoke cigarettes. They are at higher risk of having acute coronary syndromes throughout their lifetime. So just to wrap up the different types of acute coronary syndromes in a chart, you do see chest pain in all of these syndromes, but the main difference is seen in the cardiac markers and EKG changes that are due to the extent of occlusion and damage that is occurring in the heart. So now that we've briefly gone over acute coronary syndrome, we're just going to define the differences between NSTEMIs and STEMIs. And so to do this, we have to have a brief background on how to kind of read and interpret an EKG. So as you can see on the screen here, we have our normal EKG, which is consistent of our P waves, our QRS complex, as well as our ST segment and T waves. So our P wave is when the SA node is triggering, which causes depolarization of the atria, followed by your PR interval, which is where you have delay of the AV node, and this is where your ventricles are filling in your heartbeat. Next, you have your QRS complex, and this is where your ventricles are depolarizing, and this is where the main pumping of blood is occurring. Following your QRS complex, you have ST segments and T waves, which are where your ventricles are repolarizing to start the whole process of your heartbeat filling and pumping again. So now looking at the differences in a normal EKG versus those with a NSTEMI or a STEMI, you can see that in NSTEMIs we have any types of ST depression or T wave inversions, and in STEMIs we have ST segment elevation. So what does this mean? So when we see that there are certain lengths of depressions and inversions, there's certain measurements that we can correlate to diagnose our STEMIs and our NSTEMIs. So when it comes to NSTEMIs, if you look at the little schematic here, you can see that one of the small boxes is equal to 1 millimeter in length. And to measure an NSTEMI, if you have ST depression that is greater than or equal to half of one of those boxes, or if you have T-wave inversion that is equal to 1 box or more in 2 continuous leads on an EKG, that would be indicative of an NSTEMI. So when we look at the ST depression and T-wave inversions as seen on these graphs here, we would want to measure the depth of these in terms of the amount of boxes that they take up. And the same goes for STEMIs, but in diagnosis of a STEMI, we are looking for a 1 millimeter increase in ST segment elevation in 2 continuous leads. A way to kind of remember what a STEMI looks like is it's commonly referred to as a tombstone because the concavity of the ST elevation kind of looks like the head of a tombstone. So that's just something to keep in mind when you're looking at an EKG. As well as there are EKG changes, there are also changes in patients' lab values. So we see troponin levels. So troponins are cardiac proteins that are unique to the heart. So even though that they are organ specific, they are not disease specific. So as you could see at the chart on the right, you can have troponin levels in heart failure and any type of inflammation in the heart muscle, as well as in patients who have end-stage renal disease. And that is because these disease states also have some type of myocardial damage. And so the troponins are leaking due to the damage to the myocytes. But if you look at the last chart on the bottom, you can see that during a myocardial infarction, the levels of troponins are significantly higher than those in other disease states. So just one thing to keep in mind is the higher the level of the troponin, the higher the likelihood for a myocardial infarction. So now that we have kind of a little background on what EKGs are, what troponins are, and how these relate to MIs, we're going to talk about relevant guideline-directed medication therapy, or GDMT. And so when we first talk about treatment, we're going to talk about the initial treatment. So there's a schematic, it's called MONA, which stands for morphine, oxygen, nitrates, and aspirin. And these 4 medications are what you want to initiate when patients present to the emergency department when they are experiencing any type of MI. So to go over morphine, as you can see, we have the doses that are used as well as their indications and their mortality benefits or lack thereof. So morphine, we want to use morphine because pain is associated with sympathetic activation, and this can cause vasoconstriction and increase the workload of the heart. So by treating this pain, we're also treating that mechanism of myocardial damage as well. But the only thing that we saw is that there is no mortality benefit that's directly related to morphine administration. And there is some thoughts that morphine can delay the activity of oral antiplatelets. So you just want to use caution while you're using this medication. Next, we have oxygen. So oxygen is indicated when a patient's O2 saturation is less than or equal to 90%. And this is important to keep in mind because it was found that if it's used in patients who don't meet this criteria, it may actually precipitate recurrent MIs. So that's why we have these guidelines on when and when not to use medications, because they all have that risk versus benefit. And in this case, there was no mortality benefit that was found in oxygen. So next we have our nitrates. We usually start off with our sublingual dosing. And the way that these work is that they relax the coronary arteries and lower preload of the heart. And this therefore will reduce the workload of the heart and allow more oxygen to get where it needs to go. And out of all of the MONA treatments, the most important to focus on is aspirin. So when patients present, we usually give them that 4 tablets of aspirin chewed right away. And this is because it has a 23% reduction in mortality. And the way that aspirin is working is it's blocking our platelet activation and aggregation, and therefore it's effective in reducing any type of blood clot formation, and the blood clots or plaque that is already there is preventing any further damage. So what to take away from this is the importance of aspirin in acute myocardial infarctions. So after patients are treated initially with these medications, they can either be treated simply with medication management, or they might require surgical or non-surgical interventions. So the first non-surgical intervention that we'll talk about is percutaneous coronary intervention, also known as PCI. So this is a non-surgical procedure that uses a catheter to place a stent. So as you can see in the picture, what they will do is they'll use a balloon catheter to insert into the blocked coronary artery. And when the catheter is inserted here, they will inflate the balloon, which will put the stent into place. And once the stent is in place, they will deflate the balloon and remove the catheter. So now you have the stent that is holding open your blocked artery and therefore restoring blood flow to the heart. A big emphasis with PCI is that your door to balloon time is 90 minutes. So if a patient is in a rural hospital and they don't have a catheterization lab and therefore cannot perform PCI, they would require fibrinolytic therapy. So that is when you would administer your tenecteplase, your retaplase, your alteplase to stabilize the patient and therefore get them to the nearest cath lab as soon as they can. So something important to remember, door to balloon time is 90 minutes. So patients who don't have PCI, they may be candidates for a coronary artery bypass graft, or commonly known as a CABG. And so this is a surgical intervention that replaces your blocked artery with healthy blood vessels. And what they'll do is they can take arteries from different parts of your body, like the arm or the chest. And as you can see in the picture, they will directly bypass the blocked coronary artery. And by doing this, they will allow the blood to flow in a completely different mechanism and therefore just bypass the plaque blockage altogether. What's important to note is that this is a type of surgery that can prolong life and stable coronary artery disease as compared to PCIs. So this is a more permanent fix. So based on the initial therapies we gone over, we're just gonna start off with our first question. So what are the initial medical interventions for a patient presenting to the emergency department with a STEMI? So if you wanna think back to the chart on Mona, that might help you. Yes, correct. So the answer is B. So as we had the doses listed of morphine, oxygen, as well as sublingual nitrogen, and most importantly, loading the patient with 325 milligrams of aspirin. Our next question is JT is a 75-year-old female presenting to a rural hospital. She is diagnosed with a STEMI and requires emergent PCI. The closest cath lab is 3 hours away. What would you do for this patient? Yes. So the answer is A. You would want to administer fibrinolytic therapy, and that way you can have time to transfer the patient to the nearest catheterization lab, because as we spoke about before, your door to balloon time is 90 minutes. So now that we've talked about our maintenance therapies, we're going to now that we've talked about our initial therapies, we're going to move on to our maintenance therapies. So our maintenance therapies are working on remodeling what is happening after a myocardial infarction. So after MI, the heart can't pump as adequately as it could previously due to the extensive damage that occurred because of the ischemia and infarction. So scar tissue forms, and because of this, the remaining heart muscle grows and changes in shape to try and compensate for the loss of the original muscles. But this can actually progress into heart failure. And so by using our maintenance therapies, we are trying to prevent this from occurring. So the first thing that we'll talk about is beta blockers. So as you can see, we use metoprolol and carvedilol with the specific doses that are present in the chart. One thing I want to call attention to at the bottom of the avoid and caution table, we have cocaine-induced myocardial infarctions. It's important to note that in these patients, the use of beta blockers is actually contraindicated because we have beta blockade. will then have unopposed alpha activity, and this can actually cause patients who have drug-induced myocardial infarctions to go into fatal hypertensive emergency. So that's something to just keep on your differential if you may see like a younger patient, let's say in their early 40s, presenting with an MI. So the way that beta blockers are working is that they are reducing oxygen consumption of the heart by lowering heart rate, blood pressure, and myocardial contractility. And so by decreasing this oxygen demand, they play an important role in reducing reinfarctions as well as reducing complex arrhythmias from occurring in these patients. And the study that we're going to look at was a randomized trial of IV atenolol in acute myocardial infarction. This was the first international study of infarct survival. And what this study looked at was over 16,000 patients who were randomized to control groups or a group receiving atenolol. And what was very significant about this trial was that they found that vascular mortality within the first week was significantly lower in the treated group versus the control group. And so that's why when we want to start beta blockers on patients who are post-MI, we want to try and do that within the first 24 hours if indicated, because this study directly showed there was prevalent improvement in vascular mortality in a short amount of time. So our next group that we'll talk about is our ACE inhibitors. So as you can see, we'll use lisinopril, captopril, ramipril, and just certain instances in which to avoid them or use with caution. Of note, your ARBs are also indicated if patients are intolerant to ACE inhibitors. And this was seen in the Valiant study where they compared valsartan to captopril and found it was non-inferior in patients with post-myocardial infarction. So your ACE inhibitors work by slowing down ventricular remodeling and therefore allowing post-MI patients to try and return to that original ejection fraction that they had. And they also do this by decreasing afterload. So because we know that the heart is damaged after an MI, by decreasing afterload, you're kind of taking the strain off of the heart when it has to pump blood out to the rest of the body. So the study that we'll be looking at, it looked at captopril. And so the reason that captopril was looked at is because it has a shorter half-life. So not necessarily patients who have myocardial infarctions, they may not have hypertension. So patients who have borderline hypertension, it was important for the use of captopril to be used since it does have a short half-life. That way we didn't like overshoot the blood pressure for these patients. So this study looked at captopril on the mortality and morbidity in patients with left ventricular dysfunction after MIs. Just a blanket statement moving forward. Many patients who have a type of STEMI or NSTEMI, they usually also have heart failure as a comorbidity. But for the patients who don't have heart failure yet and who just have had, like, let's say their first myocardial infarction, the management is still the same regardless of the heart failure status. It's just important to point this out because many of the studies are done in patients who have both of these comorbidities. So this study looked at over 2,000 patients who were randomly assigned to either placebo or captopril. This was a randomized, double-blind, placebo-controlled trial. And it found that mortality from all causes was significantly reduced in the captopril group as compared to placebo. But more importantly, it found that the incidence of both fatal and non-fatal cardiovascular events were consistently reduced in the captopril group. So this is why the use of ACE inhibitors is important for patients post-MI because it reduces their rate of major cardiovascular events, also known as MACE events. So just to remember, with our ACE inhibitors, we know that they limit adverse remodeling, they decrease the progression to heart failure and death, as well as decrease the risk for subsequent MIs. And they also have an added benefit when used with beta blockers and aspirin. So the last group that we'll talk about in maintenance therapy is our statins. So as you see in the second column, we use atorvastatin and rosuvastatin because these are our only high intensity statins. And the study that I'll talk about on the next slide is the reason that high intensity statins are important for patients post-MI. So the way that statins work in post-MI patients is that they help to reduce reinfarction and death especially through their pleiotropic effects. So their pleiotropic effect, that means that they help to stabilize the plaque that may still be present in the blood vessels. And by doing so, they will prevent any type of plaque rupture and thrombus formation, which we know can lead to myocardial ischemia and infarction. What's important, though, to note with statin therapy is that even if patients have normal cholesterol levels, let's say they have an LDL that is normal and it is less than 70, statin therapy is still very beneficial in these patients because it is not working on reducing the cholesterol levels. It's working by stabilizing plaque. So that's just an important note to take away. So the study that we're going to talk about is the intensive versus moderate lipid lowering with statins after acute coronary syndromes. So this study looked at over 4,000 patients that were comparing 40 milligrams of pravastatin versus 80 milligrams of atorvastatin. Pravastatin being your standard therapy and atorvastatin being your intensive therapy. The primary endpoints were a composite of death from any cause, as well as myocardial infarctions and stroke. So it was found that the rates of these primary endpoints were significantly lower in the atorvastatin group. But more importantly, this study identified the superiority of the more intensive statin regimen. So this is why we use high-intensity statins. So we use our high-intensity atorvastatin and rosuvastatin because they significantly will reduce the rates of adverse cardiovascular events. And now that we have talked about our maintenance therapy, we want to focus on our dual antiplatelet therapy, also known as DAP therapy. And this is for patients who had any type of PCI or CABG. And these are based on patient-specific factors, so we'll touch upon those as we move on. So we'll talk about our P2Y12 inhibitors, which are clopidogrel, prasugrel, and ticagrelor. So these are used in addition to aspirin, which is how we get the title dual antiplatelet therapy in patients who are post-MI. And I just want to call attention to the differences in loading doses. It's important to load patients with your antiplatelets so there is no gap in therapy. Especially prasugrel, it does has some unique dosing for maintenance. It is weight-based, so if you ever see like prasugrel come across in order entry or on the floors, you want to make sure that the dose is appropriate for the patient's weight. Also with prasugrel, it does have certain contraindications and black box warnings that I'll talk about when we review the study that we are going to talk about with prasugrel. And just in general, any type of antiplatelet therapies can increase the risk of bleeding, especially with NSAIDs, because NSAIDs in post-MI patients are actually, they have a class of harm in itself because they can increase the risk of MACE events, which we briefly talked about earlier. So those are your major adverse cardiac events. So therefore, you want to try and avoid the use of NSAIDs in patients who are also on DAPT therapy. And before moving on to our questions about DAPT, I just want to point out that extended duration of DAPT therapy of at least 12 months has been associated with reductions in recurrent MIs as well as cardiovascular death, even though that these extended therapy dual antiplatelets can increase the risk of major bleeds. So it's important to just note that there are extreme benefits when using dual antiplatelet therapy for at least 12 months. So our first question is, AH is a 82-year-old man who is being discharged from the hospital after undergoing a PCI. He's being discharged on proper dual antiplatelet therapy and believes it's appropriate to continue taking his home or over-the-counter naproxen for his intermittent back pain. Is this true or false? Yes, so the answer is false. And this is because, as we spoke about, NSAIDs have a risk of MACE on their own. So you would want to counsel this patient to use a product such as acetaminophen. Our next question is, MM is a 57-year-old male weighing 63 kilograms. He is to be started on a P2Y12 inhibitor for DAPT therapy status post PCI. Which of the following options is most appropriate for maintenance therapy? Yes. So the answer is C. It would be prasugrel 10 milligrams. So as we know, prasugrel is a weight-based dosing. So this patient is over 60 kilograms and therefore would receive the higher dose of prasugrel. And the first two choices for ticagrelor and clopidogrel are the loading doses. So those are not appropriate in maintenance therapy. So now talking about the study in prasugrel versus clopidogrel in patients with acute coronary syndromes. So this study looked at primary efficacy endpoints of death from cardiovascular causes, as well as non-fatal MI and non-fatal stroke. They also looked at a key safety endpoint of major bleeding. And what they found in this study was that of the 13,000 patients, the primary endpoint occurred in less patients receiving prasugrel, so around 10% compared to around 12% in the clopidogrel group. So this showed that prasugrel was protective in preventing death from cardiovascular causes as well as MIs and strokes. But one of the important parts about this study was that they found that the rate of life-threatening bleeding in prasugrel compared to that in clopidogrel was significantly increased. So even though it helped to reduce the primary endpoints, there is a very high risk of bleeding, whether it be non-fatal or fatal, in the prasugrel group. But in regards to overall mortality benefit, there was no difference between the two groups. So even though that prasugrel may increase the risk of bleeding, it doesn't increase the risk of mortality. So just some things to take away with prasugrel. We know that it is contraindicated in the history with any history of stroke, whether it be TIA or CVA, due to that increased risk of life-threatening bleeding. We also know just take home points that is based on weight-based dosing. And there is caution in patients who are over 75 years old due to the risk of bleeding. And these patients have actually been proven to have more serious adverse events while on prasugrel. So the next study we'll look at is ticagrelor versus clopidogrel in patients with acute coronary syndromes. So this was a multi-center, double-blind, randomized controlled trial that compared the normal doses of ticagrelor and clopidogrel in the prevention of cardiovascular events. So what they found was that ticagrelor compared with clopidogrel significantly reduced the rate of death from vascular causes, as well as reduced the rates of myocardial infarction, as well as stroke, without an increase in the rate of overall major bleeding. But as you could see in bold, ticagrelor was associated with a higher risk of non-procedural related bleeding. So what this means is that if patients were going in for any type of surgical interventions, whether they be cardiac related, such as a PCI or a CABG, or they are non-cardiac related surgical interventions, ticagrelor and clopidogrel did not have any difference in the risk of major bleeding due to the surgical interventions. But ticagrelor was actually found to be associated with higher rates of bleeding in non-procedural instances. So for example, if you have an elderly patient who is at higher risk of falls, ticagrelor can significantly increase their risk of bleeding in that type of instance. So that's just something to keep in mind when you are reviewing ticagrelor on a patient's profile. And so these are the main takeaway points when we're speaking of ticagrelor. So it is actually shown that maintenance doses of aspirin that were over 100 milligrams reduce the effectiveness of Brilinta and should be avoided. So when you see ticagrelor or Brilinta on a patient profile, you want to see that they are at a maximum of 81 milligrams of aspirin, because if they go over, it can actually reduce the effectiveness of their antiplatelet therapy. When it comes to simvastatin and lovastatin, it was seen that patients who received greater than 40 milligrams a day of both of these medications were at increased risk for statin-related adverse events, whether that be myopathies, rhabdomyolysis, or increase in LFTs. It was shown that due to the metabolism through all these drugs through CYP3A4, you want to only have a maximum dose of simvastatin or lovastatin, 40 milligrams. And lastly, ticagrelor is associated with pretty significant bradycardia and dyspnea to the point where patients may need to discontinue therapy due to these adverse events. So that's just something, if you find yourself counseling a patient on ticagrelor, to tell them that these might be expected. So now our final question is, a 47-year-old patient has received an elective PCI. Which of the following represents the minimum duration of dual antiplatelet therapy that should be initiated? Yes, so the answer is D. As we spoke about earlier on, it was shown that the extended duration of DAP therapy of at least 12 months actually has significant benefit in these patients. So our last objective that we will hit upon is to recognize some factors for potential readmissions. And this is where pharmacists can play a very big role, especially when we are doing our discharge counseling. So there was a study that was posted in the US Pharmacist that showed lower socioeconomic status had substantial barriers to healthcare. So these patients can have possibly poor health literacy or lack of transportation, and these barriers can contribute to medication non-adherence as well as not being able to attend follow-up appointments. It was also shown that approximately 40% of patients who initiated guideline-directed therapy post-MI became non-adherent during the first treatment year. This can be due to side effects of the medications as well as costs. And so these 40% of patients are also at risk of being readmitted post-MI, so that is something to keep in mind. It's also seen that depression can occur in around 30% of patients after an MI, just due to the overwhelmingness of their new disease state, as well as having to change their whole lifestyle. And lastly, there are clinical metrics that are strongly associated with readmission risks. These include any patients who might have gone into cardiogenic shock while in the hospital, those who have concomitant heart failure, as well as failure of timely PCI. So if patients didn't get a percutaneous coronary intervention within that 90-minute window, that can lead to an increase in readmission risks. So just some takeaway points for this presentation. We want to stress that aspirin is key. So when we go back to our MONA chart in the beginning, this was the only therapy that helped to reduce mortality of our patients. We also need to note and emphasize that any history of stroke in patient is a complete contraindication to prasugrel. We have seen that doses of over 100 milligrams of aspirin with ticagrelor can actually decrease its antiplatelet effects. So we want to see maximum of 81 milligrams with ticagrelor use. We also have talked about how DAP therapy should be continued for at least 12 months post-PCI and then can be reevaluated. In the majority of patients, they probably will be, their PCI or their DAP therapy will be removed after 12 months and they'll just be maintained lifelong on aspirin. And lastly, and most importantly, us as pharmacists have a very important role in promoting adherence, as well as just overall patient understanding about their new disease states. So that is all I had for the presentation today. If you have any questions, please feel free to put them in the chat and I'll be happy to answer them. At this point, I'm going to stop recording though, so I can give you all the code for the CE.